Hello, my name is Dr. Avani Gajjar, and here I am presenting a case of the delirium. So, which is a history-taking case in NACOSCE station. So, one thing I like to mention before starting the video that this video is just for the education purpose only for the medical student and the doctor who are preparing for the NACOSCE examination. So, how to approach the patient? So, yeah, now come to the case scenario of Mr. X, a 65-year-old man admitted to a surgical floor, presented with strange behavior for the past 4 hours. Your on-call surgical resident for the shift. Take a focus history. So, these information are attached on the door, and you have to read the question properly. If you are asked to do physical examination, do not start taking history. You will be losing your valuable time. And you get the 2 minutes at the door to read the question, and sometimes they give the information about the blood work or any other like EKG or any other investigation report also they attach on the door. So delirium typically common in older patient with a multiple medical problem, and the 50% of elderly people who are admitted in the hospital and those who get the episode of the delirium. So at the door, when you got a 2 minute time, just write down the patient name, age, and sex of the patient and the chief complaint. So chief complaint, you can use the mnemonic of OCD, PQRST, UV plus like triple A. And the past and social history, you can use this mnemonic of PAM, HUGS, and FOSS, and write down your differential. So now I'm going to explain all the mnemonic and we'll discuss about the delirium. So what is a delirium? So delirium is the impaired responsiveness to the external stimuli. These are the few differential diagnoses which I mentioned over here. So first is a drug or toxin related. Alcohol withdrawal or medication induced, especially the narcotic, opioid, benzodiazepine, or hypnotic or anticholinergic medication. Other is an infection. The other differential is metabolic, like underlying medical condition, and the other is the structure, and the psychiatric condition also like schizophrenia, depression, or the dementia. Here is a mnemonic, the pinch me, which we can use for the any medical condition of the delirium. So the pinch me stand for the pain, infection, or the any inflammatory condition of the body, nutrition or any like cancer or neoplasma, and the constipation, and the H for the hydration, like dehydrated patient can also get the delirium, and the hypoxemia also, like low oxygen saturation level. Then the other H for the hearing, like hearing loss can also lead to the delirium. The medication induced, which I already mentioned here, and the other as a ethanol or environmental condition or any other substance use, or the eye like any cataract or any other condition can also lead to the delirium, and the electrolyte imbalance also. There are mostly the two types of delirium. One is a hyperactive, in which the patient is agitated or aggressive, and the patient have incoherent speech or disorganized thoughts, or patient also has a delusion along with the delirium. And the patient also feel the hallucination and the disoriented. The other type is hypoactive delirium, in which the patient have a sluggish behavior and the drowsy behavior, and the patient looks withdrawn. Here is the table I mentioned to differentiate between the delirium and dementia, because these two terminology are overlapping and little bit confusing. Here we can differentiate between both of them by the onset of action. In delirium, it's acute, and dementia, it's insidious or the gradual. And the course in 24 hours, in delirium, it's a fluctuating. It's not always the present. And dementia, it's a stable. And the other is consciousness, In delirium patient, it's reduced, and the dementia patient is alert. And the hallucination, the delirium patient have a visual or auditory hallucination, and the dementia patient usually it's absent. And the same for the delusion also. The delirium patient have a transient delusion, and the dementia patient is usually absent. Before entering inside the room, knock the door. And after you enter inside the room, then hand over sticker to the examiner and introduce yourself to the patient. You don't need to introduce yourself to the examiner. And whenever you take the history, sit or stand toward the patient. Then ask the patient how he or she want to address. Like after you introduce yourself the patient, then before you take the history or do the examination, remember to sanitize your hand. So here you can say like this that good morning or afternoon or evening, Mr. X. I'm Dr. Gutcher. I'm your attending physician today. And how can I help you today? Or what complaint has brought you here today? And after that, do not forget to show the empathy. Like if the patient admitted in the ER for pain, like patient have so much pain, or like a patient is a small child and the mother is talking to you, then use the word for the sympathy that I'm so sorry to hear that, and I'll try my best to help you or your son. So now begin with the history taking. Like if the patient have delirium, start asking the onset, like when did it start? Whether it's a sudden or gradual. Then the course, like it is getting worse, better, or just the same. And the duration, like it started how long ago? Like after surgery or before that, or it comes and go, or how often does it come? And whenever it comes, how long does it stay each time? And these are for the especially for the pain like PQRST. The place show me the exactly where it is hurt or where do you feel the pain. There is a quality. Tell me the quality of pain or how the pain feel. Is it sharp, burning, dull, or the crampy pain? And other is a radiation, like does it travel to anywhere else in your body? And the severity of pain, like you can just give the example to the patient that on the scale of 1 to 10, 1 is a being the mildest pain and 10 is a worst pain, how bad is it? And the timing, like it is worst at the particular time of the day or is the same. So you means your daily activity, does it interfere with your daily activity? Does it change with your daily activity? Here also you can show your empathy that how you able to manage your daily routine or activity with so much of pain. Then the other empathy you can show in severity. We already seen in previous slide that if the patient have a severe pain, then you can also show your empathy. I'm so sorry that you have to you have to suffer through a lot of pain. And the other way is the deja vu. Has it happened before? Or if it happened before, then when? And what happened then? And what medication you took it to get better? Other is aggravating factor, like what make it worse, and the elevating factor, like what make it better. And the other is associated factor. So these are the few questions you can ask to the patient of the delirium. When did you notice the behavior change? You can ask the patient or the relative of the patient, like close relative, who stay with the patient, and the duration of the symptoms. The symptoms have worsened or the improved after it started appearing. And you can ask the patient this question that orientation of the time, place, or person. And do you feel persistently cheerful or high? And do you sense things that other people don't sense? And do you hear any voices that other people don't hear? Do you feel restless or agitated? Any mood change recently? Or any thoughts of harming yourself? Or the suicidal ideation? Or any thoughts of harming other people? Or do you have any plan at the moment of the suicide or the homicide? Any change in the memory or any fever, nausea, vomiting, any chest pain or abdominal pain, any change in your bowel or urinary habit, and when was the last time you take your meal? So after that, start with the past medical history of the patient. So generally, you can ask about any past medical history of the high blood pressure or the high sugar level. Try to avoid the medical terminology in the history taking. And other main things you can ask that hepatic encephalopathy or the seizure history or any cancer history or endocrinopathy or cardiovascular disease history. And after that, ask about the any allergy. Like, do you have any allergy or are you allergic to any medication? And do you take any other medication? Like, just specify that any sedative or opioid or antidepressant or anticholinergic medication or antipsychotic medication or any other. And after that, ask the past surgical history or hospitalization in the past, and a urinary problem like burning sensation while passing the urine or blood in urine, or the bowel movement like loose stool or the constipation or the blood in stool, and the sleep pattern also. Then afterward, ask the past psychiatric history, like psychiatric illnesses and history of mania, depression, delusion, or the delirium, or any contact with a mental health person, or any past problem with the law. So after you finish the personal history of patient, then come to the family history. Whenever you transit from the personal history to the family history, just use some transit word that let me begin by asking you about your family health. Then you can ask that any family history of similar complaint, and any family history of the medical condition or the psychiatric illness, or family history of suicide or alcohol consumption or the drug abuse. And if your patient is a female, then do ask about the obstetric and the gynae history. But one thing keep in mind that when you start the drug use history or the sexual history, always say that, okay, Miss X, now I'm going to ask you a few personal questions that will help me in my diagnosis, and whatever you tell me will be kept in confidential until unless required by the law, which is very rare situation. Is that okay with you? Then after that, just begin your questionnaire by the screening question that when was the last time you had a pap smear, and any history of the STI or the use of contraceptive device, or any eclampsia or pregnancy or the childbirth history. And afterward, do you consume alcohol? And if yes, then amount and the frequency. And same for the smoke also, smoking or history also. As the duration and the frequency. If the patient used the recreational drug, then you should use the mnemonic trapped. And one thing keep in your mind that if the patient say yes to any of these questions, like either patient smoke the cigarette or drink the alcohol too much, or they use any recreational drug, then you can just use the word that we know that the alcohol consumption and the smoking are not good for our body. If you want to quit or the decrease amount of intake, I'm here to help you. You can arrange the separate session for it if it's okay for you. Now come to the social history question. So this question you don't need to ask to every individual, but more focus on the psychiatric patient or the female patient. That how's your support system at home or work? How do you support yourself? And what's your current living situation? So how's your relationship with your partner? And any risk of physical, sexual, or mental abuse. This abuse question you can ask to every female patient or the elderly patient for the screening of the abuse. And now come to the red flag that you do you have to keep in your mind that if the patient came with a hemodynamic instability or there is a sudden nausea or vomiting, or the sudden collapse case, or the pregnancy with or without eclampsia, or the extremity of the age, or the thunderclap headache, then you have to admit the patient and do the appropriate investigation according to the each differential. And these are the risk factor for the delirium. Age, like extremity of age, we already seen that the elderly people, the delirium is more common. And if the patient have decreased cognition, then the delirium is also a more common. And in the other comorbid condition like increased comorbidity, and the other is the male, the delirium is more common than the female patient, and the depression case, and the ethanol abuse, and the alcohol and the other substance abuse, also the delirium is common. So now I like to talk about investigation and the management for the delirium patient. So here I mentioned all basic required investigation in delirium patient, but you don't need to start with all of the investigation. Like after you finish your history, then you're able to figure it out that what is the reason behind delirium in your patient. So when in post encounter examiner ask about what investigation you like to do, then mention the appropriate investigation first. Then after that you can just mention all other investigation if it's applicable to the patient. And after that in management part, if it's just a history taking case, then just say that I like to do my full physical examination, and after that just mention the what is appropriate of your patient. And if the patient have very serious symptoms, and you can just say that I like to put or give some chemical restrainer like haloperidol or the lorazepam if it's required to the patient. Then at the end, just like to reassure the patient and the relative. And now, thank you for listening to my delirium history taking video.